Let's start by talking about the routine care of newborn babies in the delivery room. When babies are born, they're wet from amniotic fluid, so one of the first things that's done is the baby's dry. And then if the baby's not crying, usually it's stimulated by gently stroking the skin. You want the baby to cry, so it will bring up fluid that may be down in the lungs. If there's fluid or secretions in the airway, those are cleared, usually with suctioning, and then the baby's wrapped in blankets to keep it warm. After this, next thing to do is to put the baby on the mother's chest for skin-to-skin contact. This is good for warming the baby, and it's also good because it begins the process of the baby and mother bonding. And in this video and other videos, we'll talk about many interventions that are done for newborn babies, things like vitamin K and eye ointment and some vaccinations. But you should know that all these things can wait until the baby has had time to bond with the mother. That's always the first priority. Get the baby dry, wrapped in blankets, clear the airway, and let the baby bond with the mother. And then these other medical sort of things can be done. Let's talk about APGAR scores. APGAR scores are numbers assigned to children at the time of birth. They're assessed at 1 and 5 minutes after birth. And the way you determine a newborn baby's APGAR score is by giving the baby a score of 0, 1, or 2 for each of the following. And you can remember the 5 categories by the mnemonic APGAR. So A is for appearance, P is for pulse, G is for grimace, A is for activity, and R is for respiratory. I'll tell you exactly what all these mean in just a second. So for each of these, you give a score 0, 1, or 2. That score a baby can have is 10. And 90% of newborn babies have scores of 7 to 10. Scores that are less than 7 require further evaluation. They don't necessarily mean something bad is going on, but you have to figure out why the baby is scoring so low. Shown on this slide are the 5 elements of the APGAR score. As I said, the A is for appearance. Babies should be all pink. That gets them a score of 2. The pulse in the baby should be high, over 100. We'll talk more about this in a minute. The G is for grimace, and this really just refers to the baby's response to stimulation. You want to see a baby coughing and crying when you rub the skin or stimulate the baby. A weak response is a score of 1, and absent response is a score of 0. For activity, the baby should be fully active. A score of 0 is if the baby is limp. And then for respiratory effort, what you want to see is a good cry. A cry means that the baby's lungs are working. That's what you should see for a score of 2. A weak cry is a score of 1, and absent is 0. When newborn babies have low APGAR scores or they're having problems breathing, they need to be resuscitated. So let's talk about neonatal resuscitation. First of all, you should know that the vital signs for a newborn baby are very different than adults under normal conditions. A normal newborn respiratory rate is 40 to 60 per minute, and a normal newborn heart rate is 120 to 160 per minute. Bradycardia in newborn baby is an anomalous finding. That's because it's a marker of the baby's respiratory efforts. The usual cause in newborns of bradycardia is hypoxia. Babies have a primitive reflex that is not present in older children and adults called the diving reflex. And because of this, whenever there's hypoxia in the body and in the brain, the heart rate will go down. So when you see bradycardia in a baby, what you have to worry about is that baby is having some trouble breathing. So newborn babies who are not breathing, meaning they're apneic or who are gasping for air and have a low heart rate, are potentially very sick. The first thing to do in a baby like this is to apply positive pressure ventilation. That's what's shown in this picture here. If that fails to improve the baby's breathing and heart rate, next step is intubation. Some babies require chest compressions, and you can also give epinephrine via the umbilical vein in newborn baby to try and stimulate the heart and stimulate breathing. If the baby has labor breathing or cyanosis but the heart rate is above 100, this is actually a good sign that the breathing problem is not as severe as it could be. In these situations, usually clear the airway, you use a pulse oximeter to measure the oxygen, you administer supplemental oxygen to try and bring the oxygen level up and to keep the baby from having trouble breathing or being cyanotic. So we talked about how the normal respiratory rate for a newborn baby is between 40 and 60 breaths per minute. But there are some babies who, shortly after they're born, have a respiratory rate that is greater than 60. And those babies often have a condition called transient tachypnea of the newborn. This refers to respiratory distress in the immediate newborn period. The baby has to be tachypnic with respiratory rate over 60. The baby can have evidence of cyanosis and also evidence of increased work of breathing like nasal flaring. Transient tachypnea in the newborn is caused by slow clearance of fluid from the fetal alveoli. Remember, the baby's lungs are filled with fluid in utero, and if that doesn't clear right away, then the baby basically develops malformed pulmonary edema. The major risk factor for this is cesarean delivery without labor. When babies are delivered in this fashion, there is a lack of physiologic stimulation to clear the lungs. This normally comes with labor, but since there is no labor, that doesn't happen, and so these babies are much more likely to develop transient tachypnea. It's very high yield to know this. Important questions: the baby with this condition will almost always be delivered by planned cesarean delivery without attempted labor. The chest X-ray will show evidence of pulmonary edema, and usually this is a benign and self-limited condition that only requires support care. The baby can be given oxygen if it needs it, or positive pressure ventilation if it needs it, and rarely do you have to give oxygen at a high concentration to support babies with transient tachypnea. If the baby needs 100% oxygen or any concentration above 40, that often suggests the diagnosis is not TPN, that there's something else going on, and this usually resolves without any special treatment within about 24 hours. Most newborn babies have some degree of hypoglycemia. There's usually a transient low blood sugar that is normal in babies after birth. The reason this happens is because maternal glucose has been lost because you've taken away the placenta, so the baby has to begin producing glucose from the liver by breaking down glycogen, and this takes time for the baby to begin to do this. So usually blood sugar falls in the first 2 hours after birth and then recovers. Some babies have more persistent hypoglycemia. There's a couple of situations where this often occurs. One is in babies who are very small and have trouble producing glucose. So this can be preterm babies or babies that are small for gestational age because of fetal growth restriction. This can also happen in babies that are large for gestational age. These babies can consume more glucose right after birth, and therefore they can develop prolonged hypoglycemia. And then lastly, diabetic mothers often have babies with prolonged hypoglycemia. These babies are exposed to higher levels of glucose in utero, so their own cells are not used to producing glucose after birth, and therefore it can take them longer to begin generating enough glucose to get rid of hypoglycemia. Usually this hypoglycemia is not life-threatening or serious. It can make the baby irritable or lethargic. In rare circumstances, if it's severe, it can cause a seizure. Blood sugar is not routinely checked in newborn babies if they look well. It's only checked if there are symptoms which might be due to hypoglycemia. And when babies have hypoglycemia or symptoms from hypoglycemia, the treatment is to begin feedings, which we'll talk about in another video on newborns. Just like it's normal for newborn babies to have some degree of hypoglycemia, it's also normal for newborn babies to have increased red cell mass. This is because the in utero environment is relatively hypoxic, and this stimulates the bone marrow in the developing baby to produce lots of red cells. So in a healthy newborn baby, the usual hematocrit is about 61%, which would be very high for an adult. Splenomegaly can also be normal in newborn because of the high number of circulating red cells. If the hematocrit is greater than 65%, this is called polycythemia of the newborn, and this occurs in 1 to 5% of children. The most common cause is high yield notice rewards of polycythemia of the newborn is delayed umbilical cord clamping. Usually the umbilical cord is clamped within a few seconds or minutes after birth. But if there's a delay for any reason, then those red cells in the cord and the placenta will find their way into the baby's circulation, and that can cause polycythemia. Polycythemia is also more likely in certain types of babies. If there's any cause of intrauterine growth restriction or placental insufficiency, then the baby is not going to get enough oxygen, and that's going to cause the baby to produce more red cells. So in mothers with preeclampsia, this can lead to placental perfusion problems, and therefore the baby cannot get enough oxygen. Babies who are small for gestational age often were in utero with some problem getting enough nutrients from the placenta, and that can include hypoxia, which can cause more red cells to be produced. And then finally, postterm babies who are born at 42 weeks or later can outgrow the placenta, and therefore they cannot be receiving enough nutrients and enough oxygen, and that can lead to polycythemia. Polycythemia of the newborn is usually asymptomatic, but if the hematocrit is very, very high, that can increase the viscosity of blood, which can obstruct blood flow, and that can lead to a number of problems that are similar to infarction of organs from insufficient blood flow. Rarely, polycythemia can cause other problems like hypoglycemia. That's because the red cells use glucose for energy, and they can cause hypoglycemia. The breakdown of all those extra red cells can cause hyperbilirubinemia, and sometimes when the hematocrit is really high, the baby can simply be lethargic or have poor feeding. The usual treatment is just to observe the baby. The hematocrit usually comes down over time. Some babies are treated with hydration to prevent hyperviscosity symptoms and glucose to prevent hypoglycemia. And in rare cases, if the hematocrit is very, very high, the baby can need something called partial exchange transfusion, where red blood cells are removed from circulation. Newborn babies have an underdeveloped immune system, so they're at risk for life-threatening neonatal sepsis. And when babies develop sepsis, the symptoms can be subtle. Often the only signs are fever or irritability. So because the symptoms are so subtle, in actual practice, what you need to do is identify babies who are at high risk for sepsis and monitor them very closely. So knowing the risk factors for neonatal sepsis is very important. Chorioamnionitis is an infection of the fetal membranes that can occur during pregnancy, and babies born to mothers who have this condition are exposed to bacteria in utero and are obviously at high risk for neonatal sepsis. Babies born preterm have even more underdeveloped immune system than term babies, so they are at high risk. If the fetal membranes rupture before labor, this is called rupture of membranes, and if that is prolonged, meaning that the rupture occurs a long time before labor begins, that increases the risk that bacteria can ascend and infect the fetus. If during delivery the fetal heart rate is fast, that's called intrapartum fetal tachycardia, and this is a sign that the baby may have an infection. If the baby passes the meconium before delivery and the amniotic fluid stained with meconium, that's high risk for neonatal sepsis. And then finally, if the APGAR scores are low, this raises the risk for sepsis. In fact, if the APGAR scores are less than 6, the risk of sepsis in those babies is 36 times higher than babies with higher APGAR scores. The diagnosis is through blood cultures. You have to identify bacteria in the blood to make the diagnosis of neonatal sepsis. And the treatment is with antibiotics. The regimen often used is ampicillin and gentamicin because this covers the common bacteria. Most neonatal sepsis is caused by group B strep, which babies acquire as they pass through the birth canal. They can also be caused by Listeria or Enterococcus or many forms of E. coli, and all these bacteria are generally covered by ampicillin. Let's talk about persistent pulmonary hypertension of the newborn. So in utero, the pulmonary vascular resistance is very high, and for this reason, blood is shunted past the lungs through shunts that connect the right side of the heart to the left side of the heart. When the baby is born and begins to breathe, pulmonary vascular resistance should fall. Oxygen fills the lungs, and this normally causes the PVR to fall. In a small subset of babies, however, there is persistently high pulmonary vascular resistance, and as a result, blood is shunted past the lungs, and this causes hypoxemia. In these babies, when PVR stays high, all the fetal shunts remain open, so blood continues to go through the foraminal valley and the arteriosus, and it's not becoming oxygenated, so the baby develops hypoxemia. This presents during the first 24 hours of life with respiratory distress and cyanosis in the newborn baby. These babies usually have low APGAR scores, and for reasons that are incompletely understood, this often occurs in babies who are born with meconium stained amniotic fluid. It's high yield to know this. If they describe this as a board question and they tell you a baby has respiratory distress, the two things you should think of are pulmonary hypertension and sepsis. And this usually occurs in term infants, so it's going to be a baby that was not preterm in most cases. So when a newborn baby has respiratory distress, one of the first things that's usually done is a chest X-ray, but in persistent pulmonary hypertension, it usually shows clear normal lungs, and this is the way you can distinguish this from transient tachypnea where you see pulmonary edema. The diagnostic test from our order if you suspect this condition is echocardiogram. This will allow you to see the chambers on the right side of the heart, and you can also estimate pulmonary pressures, and they will be high. Once diagnosis is made, the treatment is supportive care in the NICU. Babies are given 100% oxygen because it lowers the PVR, the more oxygen you get into the lungs. There are also some vasodilators you can use to try and lower the pulmonary vascular resistance. One of them is inhaled nitric oxide. You can also administer intravenous sildenafil. Unfortunately, even with all these measures, many of these babies die. This is a very dangerous condition and carries a high mortality rate. So on your board exams, it will describe newborn babies in respiratory distress, and shown on the slide is a summary of some of the things you should think of. We talked about how transient tachypnea of the newborn usually resolves over the first 24 hours, and in a baby who has this condition, the board question is almost always going to be a baby who's born by cesarean delivery without labor. Respiratory distress syndrome, I talked about in another video. This is caused by lack of surfactant in the lungs, and this usually occurs in very preterm infants. And then persistent pulmonary hypertension usually occurs in term infants. Most of them are born with meconium stained amniotic fluid, so this is going to be a tip-off that the diagnosis is persistent pulmonary hypertension. And that concludes our module on delivery room care.